Just as a show of hands, how many physicians here participate or have enrolled patients in Registry? Couple. Okay, so Registry is a means of healthcare research that is based on population medicine. And what Registry classically does is embrace all of the different ways that patients present with disease and all of the different ways that clinicians take care of these patients and use the same measuring yardstick for all of them and use the same time points so that you can understand what are the characteristics of patients that come in to get treated, what are the modalities or the processes of care, the treatment modalities that you use to treat the patient, and how much does their fundamental condition change over time. The Spine Scope Registry is a surgery registry for decompression and fusion. The Vertebral Compression Fracture Registry is a cement augmentation registry for the various types of cement augmentation treatment of painful vertebral fractures. The important thing to realize is that the number of people with osteoporosis is skyrocketing, and it really doesn't matter whether you're in the US or Europe or China. The number of individuals who are in this silver tsunami are enormous. And using Registry techniques to find out the 4 important aims in taking care of patients with quality health care, that quadruple aim is to identify the right patient who receives the right procedure at the right time for the right cost. That's what value-based medicine is all about. And you must have those 4 parameters, and Registry delivers on that. Now we're talking specifically about Vertebral Compression Fracture Registry. I won't spend any time on spine surgery, but the Vertebral Compression Fracture Registry has documented that if you treat these patients and if you treat these patients promptly, you dramatically improve the quality of their life. And what these studies show is you also dramatically improve their survival. When you add up all of the patients that are in all of these cohorts, it's 3 million women. This is mostly women, the vast majority is women. 3 million women, and there's a 25 to 50% improvement in their survival if their fracture is treated with any form, any technique of cement augmentation. Now that's a dramatic improvement in their vital statistics. And one of the authors of this impactful paper was able to show that the limitation of access for women getting cement augmentation due to Medicare authorization restrictions resulted in 5,300 women dying unnecessarily and before their time and in miserable pain. So I encourage all of you to participate in Registries because you will never have enough cases in your private practices, but the synergy of all of your cases from all of your practices enrolled in a registry can significantly alter national policy. And that's what the Vertebral Compression Fracture Registry did. Registries are different than randomized control trials. Randomized control trials are very much like a Kodak Instamatic camera. They will take a picture of one point in time with one set of criteria under one set of circumstances because the other circumstances are listed in the exclusion criteria that do not get studied. Registry, however, is very much like a GoPro. It is constantly moving. It examines all environments. It restricts none of the heterogeneity of the disease of the patient. So all different peoples of all different types with the condition are measured, and it doesn't restrict any of the treatment. So all of the heterogeneity of treatment is embraced. So you find out what's the right patient that gets the right procedure, and you find out when's the right time to do it. And if it's done in all care environments, you find out where is the least expensive, most effective. And that's what they do. So the Instamatic and the GoPro are really very good analogies for this. The vertebral compression fractures occur in the classic regions of the thoracic and lumbar spine, and thoracolumbar spine particularly. The purpose of the registry is to identify that quadruple aim: right patient, right procedure, right time, right price. And you can summarize that as the best course of treatment for the patient. That quadruple aim is summarized by that. The great thing about the procedure is you can do it under local anesthetic. You can do it in an ambulatory surgery center. You can do it under general anesthesia in an inpatient setting. This is the data on adverse events and readmissions. And this is important data because you want to know, first off, do the results of registry pass the smell test? Meaning, does it smell right? Does it not smell right? Well, you know from your own literature that cement leak is published in over 100 articles to occur between a frequency of 20% and 67%, depending upon your technique. And in this setting of individuals from all across the country, the cement leak rate was right where it ought to be, 1 out of 4 people. What you also see is none of those individuals had a neurologic deficit. So cement leak in and of itself is not dangerous, but it serves as a signal that danger is nearby so you can alter your procedure. So it's important to see it. You'll see it 25% of the time. When you look at the death rate for 732 women, there's actually 1,100 in the group, but the death rate is dramatically lower than you would expect for someone that age. So that indirectly verifies for you that cement augmentation is improving their vital statistics. It's improving their survival. And then lastly, what we find is these are elderly women, so you should expect them to come back into the hospital. They will come back for a variety of reasons that don't have anything to do with their osteoporosis, but they can come back with a hip fracture. They can come back with urinary tract infection, atrial fibrillation, confusion. And that also passes the smell test because that's what the emergency room sees in non-osteoporotic populations, this age group. So the registry indirectly validates itself. Also important is the outcomes of the timing of care. If someone is treated immediately the day of their fracture, their pain relief and functional improvements are highly impressive. They are more superior than we get from total hip and total knee replacement. If you delay their treatment by 6 months, they are still profoundly affected by the condition. They still get dramatic improvement, not as good a functional improvement as they got with immediate care. But most importantly for the payer, for Medicare and the Medicare administrative contractors, and this is a real important aspect of registry, as you get healthcare utilization data. What Medicare noticed, if they got out of the way and the patient got treated promptly, it was at the lowest cost with the highest outcome. And if their care was delayed through authorization, readmission, discharge to skilled nursing facility without treatment, then readmission to the emergency room, their cost tripled. And at the end of 6 months of suffering, you still got a good result. So all you did for 6 months is waste money. And if you multiply that by 700,000 fractures per year, that's a great deal of savings. And participating in registry will allow you to demonstrate that in your practices. So I strongly recommend you consider participating in Registry. It has direct and indirect benefit for the patient, indirect benefit for the clinician. And now these are the primary outcomes that were in sentence form, text form. And these are the graphs. Numeric pain scale is 0 to 10. 10 is horrific, hospice level, terminal pain that Easy was talking about earlier, his pump patients. And you see that there is immediate and dramatic improvement in pain. And that is a 5-fold minimal clinically important difference. So the MSID in our surgical practices is very important. And having a 2-fold MSID is considered very strong evidence for benefit. And you see here in both pain and function, 5-fold improvements in pain and function. This is the registry itself. You recognize some of the names of people here, but this is from across the country. This is from the Pacific Northwest, University of California, San Francisco, University of Wisconsin. That is one of the nation's premier PCORI researchers from the University of Washington, and here, Oklahoma. And what we find with the registry is the things you expect to find do in fact occur, but they have no adverse consequence to the patient. And that the pain improvement is real. It is really impressive. And the function improvement is real, and it's really impressive. And it's real world. It's what happens in communities all across the country. What registries allow you to do is to influence the 5 Ps that are healthcare stakeholders. And that's the patients, the physicians, the policymakers, Medicare, the product and device manufacturers, and it allows you to also publish the merits of your good work. And what you see from this is that when you publish real world data, you can have significant impactful change in the practice of medicine. And the work to do this is imperceivable in your practices. These tools are now electronic so that you don't need to do human abstraction. The completeness of data rate is very high, and the accuracy of data is very good. And so I recommend that going forward, you use the advantages of a GoPro to be able to see not only in the environment in which you practice, but see in environments outside of your practice, and to be able to see things in real time. Any questions? Yes.
Thank you so much. Very impressive data. The randomized controlled trials compared to the registry, are you finding that the results are congruous, incongruent, or equivocal when you're comparing those two?
So the question is around a comparison of randomized controlled trial and registry. The important thing to realize about randomized controlled trial is it's a highly structured study. And so it has a very high complete data set because you won't use incomplete data in a randomized control, it drops out. And its purpose is to identify the outcome of the design of the study and whether it's true or false. So you're pursuing a hypothesis. Registry is not research. Registry is quality improvement. Registry is what Toyota and Boeing do in the process of building cars and aircraft. They look at the process, they see where they can improve it, they find out in outcomes of their planes and cars where the faults are, they go back to manufacturing and they improve it. So in a randomized controlled trial, you are frozen into the criteria of inclusion and exclusion. In registry, you are doing quality improvement along the way. So they are not designed to be comparable, or to say it another way, the best way to do randomized controlled trial is on the back of a registry, because the registry will tell you what your N number is for the study population, the subcohort population you want to study, and it'll tell you right away how many hits of that data point you have, and you will know right away whether that's a successful trial. So I don't look at them as either or. I look at them as running separately, but they can be run in tandem or more correctly in sequence, one after another. Registry first. I hope that answered your question. Any other questions? All good. Thank you.